Biliary system, physiology, bile. Adults secrete normally from 250 to 1000 milliliters bile per day. Control, neurogenic, vagal stimulation increases secretion, whilst planktonic stimulation decreases the bile flow. Normal, HCl, protein breakdown products, and fatty acids stimulate secretin release from the duodenum to stimulate bile secretion. Composition. The main constituents of the bile are water, electrolytes, bile salts, cholesterol and phospholipids, bile pigments. Electrolytes, they are of the same concentration as the plasma. Bile salts, the major bile acids which form these salts are cholic, deoxycholic, and chenodeoxycholic acids. These acids conjugate with taurine or glycine to form bile salts. Cholesterol and phospholipids. Cholesterol is insoluble in water and is carried in the bile by combined detergent effect of bile salts and phospholipids. Bile pigments, bilirubin diglycuronide is the breakdown product of hemoglobin. It's responsible for the yellow color of the bile. Gallbladder function, stores and concentrates bile. Sodium chloride and water are selectively absorbed, tenfold increase in the concentration of bile salts, bile pigments and cholesterol. Mucus secretion, protects the mucosa from the lytic action of bile and facilitates passage of bile through the cystic duct. Contraction of gallbladder and emptying of the bile for digestion. Humoral stimulation, food releases cholecystokinin from the intestinal mucosa, leading to contraction of the gallbladder and relaxation of the sphincter of Oddi, evacuation of 70% of gallbladder within 30 minutes. Nervous stimulation, vagal innervations stimulate contraction, whereas the sympathetic stimulation inhibits motor activity. Imaging investigations, abdominal ultrasound, the first investigation performed in most biliary system disorders. Advantages, it's easy, simple, inexpensive, non-invasive investigation, done in the presence of acute inflammation or jaundice. It can provide the following information: detection of gallbladder stones in 98% of cases, detection of stones of the common bile duct, it's less accurate, about 1/3 of the cases are detected by ultrasound, detection of thickness of the wall of the gallbladder, visualization of dilated extra and intrahepatic biliary ducts in patients with surgical obstructive jaundice, detection of masses in the porta hepatis or head of pancreas. Plain X-ray is of limited value, detects gallstones in only 10 to 15% of cases. Gallbladder with a calcified wall, porcelain, can be seen. Air in the gallbladder in acute emphysematous cholecystitis. Air in the biliary system after choledochoduodenostomy or sphincterotomy operations. Oral cholecystography was previously the investigation of choice for detection of gallstones, but it's now replaced by ultrasonography. Endoscopic retrograde cholangiopancreatography or ERCP method. An endoscope is passed through the esophagus, stomach, and duodenum. The duodenal papilla is localized and a cannula is passed in it. Contrast material is injected to visualize the common bile duct and the pancreatic ducts by radiography. Indications: diagnosis of lesions involving the lower end of the common bile duct, such as carcinoma of the head of pancreas or ampulla of Vater. A biopsy can be taken. Detection of missed calculi in the common bile duct after cholecystectomy, detection of operative injuries in the biliary system, visualization of the pancreatic duct in patients with chronic pancreatitis or pancreatic pseudocyst. Therapeutic procedures can be performed with the ERCP, sphincterotomy, and removal of the bile duct stones, insertion of a stent to drain malignant obstruction of the duct. Complications: acute pancreatitis or duodenal perforation, ascending cholangitis, most common, or septicemia after injection of the contrast material in presence of unrelieved obstruction in the common bile duct due to increased pressure of the common bile duct. Magnetic resonance cholangiopancreatography (MRCP), providing good quality images without the complications associated with the ERCP or PTC. Diagnostic, but it's not therapeutic, so it's of limited value. Percutaneous transhepatic cholangiography or PTC. Prerequisites: normal coagulation, the prothrombin time and concentration are checked. If the prothrombin time is prolonged, vitamin K is given IV for a few days to correct hypoprothrombemia before the procedure. Dilated intrahepatic biliary radicals are seen on ultrasound. Technique: under local anesthesia, a thin cannula called Chiba needle is introduced through the 8th intercostal space into the lever, and continuous suction by syringe is applied until bile is aspirated and the dye is then injected. The dye will visualize the intrahepatic biliary ducts and then view the bile duct from above downwards. Indications: diagnose high obstruction of bile ducts as in post-operative biliary strictures or in hilar cholangiocarcinoma. Complications: biliary peritonitis, bleeding may occur if there is hypoprothrombemia. Endoscopic ultrasound useful for the diagnosis of ampullary or pancreatic carcinoma. Radioisotope scanning or HIDA scan method, 99M technetium labeled derivative of the aminodiacetic acid, HIDA, is injected IV, rapidly excreted by the liver to visualize the biliary tree. Uses diagnosis of acute cholecystitis by the non-visualization of the gallbladder because this means obstruction of its neck. A gallbladder that fills by the isotope excludes it. Diagnosis of congenital biliary atresia and to visualize biliary enteric anastomosis. Gallstones incidence more common in Western countries due to dietary factors, occurring in at least 20% of women over the age of 40 in these countries. A female-to-male ratio is 3:1 in cholesterol and mixed stones. Increased females' incidence is not present after the age of 60 and with pigmented stones. The incidence of gallstones increases with age, and there is familiar incidence of the disease, more common in parents and siblings of the patients. You have to know those important definitions. Cholelithiasis means gallbladder stones. Cholediculithiasis, common bile duct stones. Cholecystitis, inflammation of the gallbladder. Cholangitis, infection of the bile ducts. Types and composition of the stones. We have pure cholesterol stones, mixed stones, pigmented stones, black and brown. For the incidence, mixed stones is 90%, the black in patients with hemolytic anemias or cirrhosis, while the brown is infected stagnant bile in the bile duct in the presence of foreign bodies such as biliary stent. For the pure cholesterol stones, it's formed of 100% cholesterol, number, single, and it can sometimes be multiple, size, more than 2.5 cm, rounded in shape, yellow in color, and in X-ray it's radiolucent. For the mixed stones, cholesterol forms more than 60% of the constituents of this stone, plus calcium bilirubinate, calcium phosphate, and calcium palmitate. The number is multiple, size from 0.5 to 2.5 centimeters, shape faceted, color yellowish, X-ray radio-opaque, and 15%. For the pigmented stones, the black stones formed of calcium bilirubinate, number multiple, size less than 2.5 centimeters, the shape multiple spicules, color tarry black, and in X-ray radio-opaque in 50%. For the brown pigmented stones, it's formed of calcium bilirubinate mainly, plus calcium palmitate and cholesterol, number multiple, size less than 2.5 centimeters, shape laminated, color brown, and in X-ray it's radio-opaque. Etiology. For the cholesterol and mixed gallstones, we have disturbed bile stones to cholesterol ratio and stasis of bile. Disturbed bile stones to cholesterol ratio. Cholesterol is insoluble in water, carried in bile by the combined detergent effect of bile salts and phospholipids, which form clusters, a certain ratio, 25:1, and this is between bile salts and phospholipids on one hand and cholesterol on the other hand, and it has to be maintained this way to keep the cholesterol in solution. Any lowering of this ratio leads to formation of supersaturated bile, lipogenic bile, and cholesterol precipitation. The following factors disturb this ratio, such as reduced bile salt pool or increased cholesterol synthesis. Increased cholesterol synthesis occur in obesity, high dietary fat, and high caloric diet. Reduced bile salt pool, malabsorption of bile salts in the terminal ileum, as in Crohn's disease, small bowel resection, bypass procedures. In diabetic patients, autonomic neuropathy of the ileum occur and it affects enterohepatic circulation, decreasing the bile acid pool. Diminished hepatic synthesis in the liver diseases, and estrogens reduce the concentration of bile salts in bile. Liver cirrhosis is associated with increased incidence of gallstones overall, but more oftenly black pigmented stones. Most gallstones are silent and remain so for 70% of the patients. Diagnosed as incidental finding on ultrasound, symptoms such as recurrent biliary colic develop in 2 to 3% per year. Each year, 3 to 5% of symptomatic patients develop complications. Stasis of bile. It occurs in obesity, diabetes, following truncal vagotomy due to denervation of the gallbladder, long-term parenteral nutrition. Lack of oral intake prevents release of cholecystokinin. Female hormones, progesterone, relaxes and impairs emptying of the gallbladder. Estrogen and oral contraceptives with repeated pregnancies increase incidence of gallstones. Pigmented stones. For the black pigmented stones, hemolytic anemias and liver cirrhosis. Hemolytic anemia is any condition which shortens the lifespan of the RBCs, hereditary spherocytosis, thalassemia, or prostatic heart valve. Liver cirrhosis due to decreased secretion of bile acids by the cirrhotic liver, leading to diminished solubility of the unconjugated bilirubin. Brown pigment infection by some strains of E. coli, leading to production of B-glucuronidase enzyme, hydrolysis of bilirubin glucuronide into insoluble bilirubin, which precipitates as calcium bilirubinate. Complications: they are divided into two sections: whether the stone stays in the gallbladder or it migrates. If it stays in the gallbladder, it causes gallbladder cancer, chronic calcular cholecystitis, acute calcular cholecystitis plus or minus emphysema or gangrene or perforation. If it migrates to the common bile duct, leading to cholangitis, pancreatitis, obstructive jaundice, or duodenum through the fistula, leading to gallstone ileus. Complications in the gallbladder: obstruction of the cystic duct or neck of gallbladder, mucocele of the gallbladder if the contents remain sterile, and acute calcular cholecystitis if contents infected, with or without empyema, gangrene, or perforation. Chronic calcular cholecystitis: the gallbladder is usually thick-walled and contracted. Carcinoma of the gallbladder, long-standing calcular disease, leads to squamous metaplasia, leading to carcinoma. About 90% of patients with carcinoma of the gallbladder have gallstones. Complications caused by migration of stones: migration to the common bile duct leads to obstructive jaundice, leading to bleeding tendency, septicemia, renal and hepatic failure, cholangitis and cholangitic abscesses of the liver. Acute pancreatitis: if a stone in the lower end obstructs the common channel of the common bile duct and pancreatic ducts. In many cases of calcular pancreatitis, there is no actual obstruction of the ampulla during the attack, but it's suggested that passage of the stone through the ampulla may precipitate pancreatitis by an unknown mechanism. Biliary cirrhosis, rare in long-standing intermittent obstruction. Migration to duodenum through a fistula: we have gallstone ileus, rare. Big stone more than 2.5 centimeters passes through a fistula between the gallbladder and duodenum, impacted in the terminal ileum about 2 feet from the ileocecal valve, leading to intestinal obstruction, called gallstone ileus obstruction. Clinical diagnosis is usually difficult because the patient is often elderly and giving a long history of biliary problems. The symptoms of intestinal obstruction are usually misinterpreted as being due to biliary problems. Clinical picture: asymptomatic, silent. This is the most common presentation, accidentally discovered by plain X-ray or ultrasound performed for another abdominal problem. Symptomatic: we have recurrent attacks of biliary pain, biliary dyspepsia, and reflex symptoms. Recurrent attacks of biliary pain: this is the usual complaint, site in the right hypochondrium, referral to the back of the right chest or right shoulder, course, constant, increases in severity over 30 minutes, duration, lasting less than 5 to 6 hours. If longer than that, this means acute cholecystitis, precipitated by intake of a fatty meal. Associated symptoms: nausea or vomiting during the attack, biliary dyspepsia, fat dyspepsia with bloating and excessive eructations following fatty meals. Sometimes these patients are diagnosed as having peptic ulcer or chronic colitis. Reflex symptoms: reflex retrosternal pain, which is diagnosed as anginal pain. This is called cholecystocardiac link. Actual ECG changes may occur. Signs: tenderness in the right hypochondrium, Murphy's sign is positive, the gallbladder is palpated while the patient is asked to take a deep breath, and the patient will catch his or her breath. Complications may be the first presentation, which is obstructive jaundice. Investigations: abdominal ultrasound is the investigation of choice. Simple, inexpensive, non-invasive technique. It can provide the following information: detection of gallstones in 98% of cases, thickness of the gallbladder wall. Thickened wall means long-standing recurrent inflammations, the diameter of the common bile duct, and any intrahepatic biliary dilatation. If present, this means stone in the common bile duct. Ultrasound can see almost all gallbladder stones and only 1/3 of the common bile duct stones. Treatment: asymptomatic cases, no treatment is needed. Prophylactic cholecystectomy is only indicated for elderly diabetics, increased morbidity and mortality if acute cholecystitis develops, and porcelain gallbladder was previously an indication but is now not considered precancerous. Symptomatic cholecystectomy, the standard treatment, done whether by open or laparoscopic method. Extracorporeal shockwave lithotripsy as well, and medical dissolution of the gallstones. This was popular in the 80s but is now obsolete. Acute calcular cholecystitis pathology: gross picture, the gallbladder appears distended in shape, thickened wall showing multiple microabscesses. Cirrhosis loses its bluish luster and covered by fibrinous deposits. As a defensive mechanism, the greater omentum, duodenum, and colon become adherent to the gallbladder to localize infection. Consequences: we have 4: resolution, obstruction, and empyema of the gallbladder, plus recurrent attacks. Recurrent attacks leads to chronic calcular cholecystitis. Empyema of the gallbladder is converted to a closed bag of pus. Obstruction persistence, this is less common. It leads to progressive distension, thrombosis of blood vessels, gangrene, perforation, and finally peritonitis, whether localized or generalized. Resolution in most cases with treatment. The stone is dislodged and the obstruction is relieved with gradual resolution of inflammation. Etiology of the acute calcular cholecystitis: calcular 98%, secondary to obstruction of the cystic duct or Hartmann's pouch by a stone, pathogenesis, obstruction of the cystic duct or neck of the gallbladder by a stone, leading to infection by gram-negative bacilli, acute cholecystitis. Clinical picture, symptoms and signs. Symptoms: nausea or vomiting, abdominal pain. At first, it's diffuse, colicky upper abdominal pain. Later, with inflammation of the serosa, it becomes dull aching pain, persistent, and localizes in the right hypochondrial region. Referred to the right shoulder due to irritation of the diaphragm by sensory fibers of the phrenic nerve. Duration: pain more than 6 hours equals acute cholecystitis. Signs: general, pyrexia, tachycardia. Local abdominal examination reveals tenderness, rebound tenderness, and muscle guarding in the right hypochondrium. Difficult to palpate the distended gallbladder due to overlying tenderness and rigidity. Special signs: Murphy's signs and psoas sign. Murphy's sign: if pressure is applied to the right hypochondrium and the patient is asked to take a deep breath, he will hold his breath. Psoas sign: areas of hyperesthesia between the 9th and 11th ribs on the right posterior part of the body. Acute emphysematous cholecystitis: it's a special form which may occur in diabetic patients due to infection by anaerobic organisms such as Clostridia. It's highly virulent and accompanied by gas formation, early gangrene of the gallbladder. Meritzi syndrome: a large stone impacted in the Hartmann's pouch, compressing the bile duct from outside, leading to obstructive jaundice. And this is the only case of acute calcular cholecystitis which is characterized by jaundice plus pyrexia plus tachycardia. Investigations: lab, blood picture, polymorphonuclear leukocytosis may be present, liver function tests usually normal, imaging, abdominal ultrasound, the most appropriate, reveals presence of gallstones, distended gallbladder with thickened wall, showing microabscesses and serosal edema due to spreading of inflammation. Differential diagnosis: perforated duodenal ulcer, acute pancreatitis, high retrocecal appendicitis, right pyelonephritis, and amoebic hepatitis. Again, amoebic hepatitis, right pyelonephritis, high retrocecal appendicitis, acute pancreatitis, and perforated duodenal ulcer. Treatment: early cholecystectomy within 3 days if we have confident diagnosis, fit patient, and experienced surgeon. The definitive treatment is cholecystectomy, and it has the following advantages. Early surgery is not as difficult as it seems because adhesions are fibrinous, not fibrous, avoiding the complications of acute cholecystitis which may arise during conservative treatment, and 1 hospital admission with early return to work. Initial conservative treatment followed by cholecystectomy after 6 weeks if more than 3 days have passed. Nil by mouth and IV fluids, antibiotics against gram-negative bacilli as ampicillin or cephalosporins, analgesics as betadine or NSAIDs, follow-up of the pulse, temperature, area of tenderness, and rigidity. Most patients improve under this treatment. The patient is sent home and advised to come back later for elective cholecystectomy after 6 weeks to allow adhesions to subside. If the patient deteriorates during treatment, surgery should be performed, and we have 2 modalities: cholecystectomy, if safely feasible, and cholecystostomy, if adhesions are present, which makes cholecystectomy a risky operation. Cholecystectomy means that the gallbladder fundus is opened and the stones are removed. The gallbladder is drained by a tube for 1 week. The patient usually returns for elective cholecystectomy after 6 weeks. Acute non-calcular cholecystitis etiology: it's a rare and serious condition which may occur in patients suffering from major burns or major trauma, patients on prolonged total parenteral nutrition, and it may complicate certain infections as brucellosis and typhoid. The actual cause and pathogenesis are unclear and may be due to change in the composition of the bile or ischemia of the gallbladder. Clinical picture: similar to that of the acute calculous cholecystitis, but usually diagnosis is delayed because it's not suspected, and that's why mortality rate is higher than calcular cholecystitis. Investigations: ultrasound examination is diagnostic. Treatment: successful percutaneous cholecystostomy followed by cholecystectomy after being admitted out of the ICU. And this concludes part 1 of the biliary system.